So, hello, everybody. I'm so glad you're at this conference and I get the chance to do this with our wonderful customers. My name is Sava Berhane, and I have the privilege of being Care Message's Chief Revenue Officer. I lead our efforts to help the organization grow sustainably so that we can advance our mission to improve health equity for low income patients. But in addition to that, as you heard about Objective 3, to also reduce access barriers to technology for safety net organizations. I really, I really come to this work really from a personal perspective. So I think it's important to just share what grounds me in the work, as we always do at Care Message. I grew up in the communities that our health centers serve, in homeless shelters, in Section 8 housing, navigating the language barriers that affected my Ethiopian mother and my siblings. And I was the first in my family to graduate from high school, college, law school. And it really was the community health centers in my communities that cared for me and my family when we were uninsured and on Medicaid that made the American dream that I live possible. I wouldn't be sitting in this seat today at Care Message if it weren't for healthcare. I think, and we all think, those of us on this call, that healthcare really is foundational to equal opportunity. What I've learned working alongside these wonderful women and our customers is that really success in the safety net is not by accident. It requires intention, cultural humility, disciplined workflows, and relentless persistence. So today we have the most powerful question we can ask, which is, what does success look like when we're trying to achieve preventative care screenings, specifically colorectal cancer screenings in the safety net? While many organizations that use Care Message and many that don't are still striving to meet the national benchmarks, the leaders on this panel, Mikala, Erin, all of you are, and Megan, are all of you have essentially exceeded those benchmarks. And you're serving patients from different geographic barriers, language challenges. You have funding constraints that we've talked about in the past, and workforce shortages that affect the work that you do. And so the conversation today isn't just about the numbers, it's about what actually works and how it works. So let's pass it over to you and start with introductions. I introduced myself, and I'm going to go ahead and pass it over to Erin.
Great. Hi, everyone. Hi, Sava. Thanks for inviting me and having me. You want me to introduce myself and a little bit about PrimeCare?
Yeah, your name, your role at the organization, and what keeps you motivated to do this work.
My name is Erin Howes. I'm the Chief Population Health Officer at PrimeCare Community Health. We are an FQHC in the west and northwest neighborhoods of Chicago. I've been here for 8 years, but I've only worked in FQHCs in different roles, case management, data analytics. So kind of just working through the health center and getting to experience different roles. I am super passionate about data. I'm very competitive. That's like kind of at the root, but I also am very passionate about healthcare as a human right. Cancer screenings, I'm sure like all of you, we've all been impacted by this. It's easy to stay driven, I think, because you view all the patients as your own family members who have been through this. And then when you pair that with data and friendly competition, it's just a match made in heaven for me. So yeah, that's a little bit about me.
Thank you. We'll go to you, Mikala.
Good morning, everyone. I'm Mikala Balk. I am from Phoenix. I work with Wesley Community and Health Centers. We're a small FQHC here. I've been with them for about 5 years. I would say what drives me is just access to care. I have a personal health journey story. I had breast cancer when I was 25. And even though I was insured, I had a really large deductible. And I remember there was one day before one of my chemos, I was told I owed, a balance. And if I didn't pay that they were going to send me to collections. And I just remember saying, I'm sitting here trying to fight for my life. And here you're trying to tell me I owe money. And so even though I was insured and I'd never even heard of FQHCs at that time, it just, like she said, it's basic human right to have health care. And so access to care is a huge thing to me, and that nobody has to fight for their care. And so here I am. And so that's what we do every day at Wesley.
Thank you, Mikala. Megan, we'll go to you. We're going to have you unmute, Megan.
Okay, try again. Thanks. Hi, I'm Dr. MacKiernan. I am a Chief Quality Officer at Norton Sound Health Corporation here in Nome, Alaska, where it's still very early. And we are a tribally owned and operated healthcare center that serves primarily Alaska Native and American Indian patients. And we serve about 10,000 lives across a region about the size of the state of Ohio. We are the only healthcare provider in our region. And I've been here about 13 years. I supervise our quality, risk, EHR, population health, and a few other departments. And we're really working to integrate care for our population. Alaska Natives have the highest rates of colon cancer in the world. And so, this has been a big focus for us. Personally, I came here with National Health Service Corps 13 years ago, thinking I was only coming for a couple of years, and I've fallen in love with the region and the care that we provide.
Thank you so much. Thank you all. Just to ground us for a moment, we had talked at the top of this conference about how colorectal cancer remains the second leading cause of death, cancer death in the United States. And yet it's one of the most preventable diseases. When detected and caught early, it has a 5-year survival rate over 90%. And yet we don't detect it early. So when we look at screening rates like yours, 74%, 63%, 50% across the three of you, it's incredible progress. It's extraordinary. So can you just think back to where your organization began with respect to, I like the healthy competition piece, but with respect to achieving these goals, what were your screening rates then when you started out? And how did you iterate your way to where you are today with screening rates? I'll start with you, Erin.
Sure. So a little bit about PrimeCare and Chicago. We do skew older. We serve 31,000 patients a year. And compared to like our local FQHCs in Chicago, we're kind of like the older folks go to PrimeCare. So I've been really invested in this. And for me, like I looked about 5 years back, just, looking at UDS data, we were at 61% in 2020. And so it's like only been right a 4% improvement in the past few years. But what I try to tell my staff and to all of you is that we're also just looking at the sheer number of people that we're screening. And so the big thing for me has been holding on to that percentage. And again, for someone like me who's obsessed with the rates, I'm like, oh, it didn't move. It didn't move. But especially with the age, decrease in eligibility, we were in 1 year able to get our screening rates for the 45 to 49-year-olds to match what we had already had for the 50-year-olds and above. And so we went from screening, having, our numerator, right, of people screened to being like 3,300. And for UDS 2025, we just submitted 5,700 people screened. So like the rate has stayed pretty steady, but I'm like, we have 2,000 more people that were screened for cancer. So I'm trying to look at both. So that's a little bit about where we've been. But honestly, if we can just keep getting like 1% every year, I'm happy. And we want to just keep chucking away at it because it's so many people behind that 1%.
Yeah, those year-over-year increases have a tendency to kind of impact operational workflows too. You almost have to get even more precise, even more scalable as you grow year over year, especially someone who's like, we are going to achieve this, we're going to execute it. Is there one operational change that occurred between those year over year increases, Erin? And then
yes, many, but I would say our favorite so far, my favorite, I wanted for years to partner with Exact Sciences to offer Cologuard. Yeah. Years I advocated for this and I finally got it in 2025. So, oh my gosh, just hundreds and hundreds of people already completing that test this year. And now they'll be good for 3 years, right? So we'll see, I hope, that improvement because the access to colonoscopies is just becoming ridiculous. I'm sure people think like, oh, Chicago, like, no, I think we all have these barriers. I mean, it can be a year-long wait for some of these people to get a colonoscopy. And that's if they can pay. all this
Right.
money to have one. So
Right.
that's been a huge win operationally.
Absolutely. What about you, Mikala?
I would echo that, you have to look at those little wins. It's not always going to be, oh, we went up 10%. That 1% makes a big deal. I think for us, we really started, it's kind of a team approach, right? We started looking at it and posting our numbers weekly for everyone in the clinic to see, the MAs, the front desk, the providers, everyone to see it. So we're watching that number. And then we started really looking at our patient education, because what we found is we were giving out our fit tests constantly. Nobody's bringing them back, and patients were so weirded out about, like, oh, I have to touch my poop, or you
Right.
need a poop sample, so we now just have a tray in our clinic, and it's just it's our kind of our education tray, and we show patients. And I really think getting the MAs on board and really just kind of destigmatizing that
Yep.
really has made a big difference. And we partner with, we use Azara and their outreach campaigns, and it sends a text through care message, 24 hours, 72 hours, 7 days, 14 days. And that's made a huge improvement as well, because the patient's reminded, because you get all these things when you leave the doctor's office, it leaves your brain. You go back to real life. It's great in that moment. Yeah, I'm going to do this. And then you throw it in your car or wherever and you completely forget, So
Yeah. I
it's,
love I
it's,
love the
it's,
humanity that you bring to this, Mikala, because you said,
it's really
you
taken.
have to destigmatize, right? You have to meet the patient where they are and recognize why one channel of communication might be less effective than another because of how one might feel about what you're asking them to do. And then you mentioned how you're doing the outreach. I'm curious, even, does the type of message that goes out, the way that a message is communicated, or were there other kind of operational choices you made that you feel helped patients really interact with and engage in these screenings?
Yeah, so when we always make sure, so we have a large, I think one of the biggest things for us is we really look at how we communicate. We look at the verbiage that's used. We look at the languages that it's offered in, because we have a refugee clinic as well. So we have a lot of different languages. We have a lot of different just educational barriers to patients. So, and some of our patients even ask to do it in the office, so it's giving them all opportunities to get it done. And I really think the destigmatizing and then just talking about them every time they come in, we remind them if they've had one and they didn't complete it the next time they come, and just constantly having that be as normal as you hear about mammograms all the time, having this be the same type of thing that you're hearing about it all the time. Your PAP is every, however many, often that you get that, same thing, just making it a normal test that patients are completing. And now they're kind of in the, oh, okay, that's what I do every year. It's getting that. I don't think that's out there enough, that this is just like a
Exactly.
mammogram. This is just like your PAP test. These
Exactly.
are things that you should be doing for preventative care.
Normalize, destigmatize, and
Yes,
using tools that meet patients where they are. I love that.
correct.
All right, Megan, what about you?
Yeah, so in our region, we have, like I mentioned, just really high rates of colon cancer. And so a lot of our patients are not eligible for fit tests due to family history. So, but we did try a big fit test campaign. And like she just said, we didn't have big take up. We mailed out a ton of kits and reminders, and we didn't get a ton back. So we really have put our effort toward colonoscopy. We offer colonoscopy clinics at our hub center in Nome, and we've had one provider who comes now 2 weeks out of every month and does those. And we actually have trained up two of our family practice providers to also do colonoscopies in our primary care clinic. And so we're able to increase our volume there. The complication for us is that every colonoscopy for our patients from our villages, which is about 2/3 of our patients, requires air flight, hotel stay, and
Wow.
an escort who also needs flights and hotels and food and all of those things. And so logistically, it's a little bit of a nightmare. So our procedure tech from our colonoscopies also acts as the case manager for that department. and she coordinates directly with patients and families, all of that travel, all that coordination, handling the weather cancellations and delays to get our patients in and to keep all of those clinics with our providers full, and getting all the patients the follow-ups and whatever is needed. And we really have found a lot of success with that, but it's very intense level of case management. But utilizing that procedure tech, who's also a CMA, has been really effective.
Yeah, you're reminding us that serving these patients is about whole person care. You have to think outside of just what the engagement looks like when they're at the clinic. It's all of these things that are outside of the clinic, like actually being able to get to the health center in the first place, that matters as well. And we shouldn't underestimate those challenges. Erin, Mikala, and Megan, um, I really love the energy around sharing the data. Mikala, you were talking about sharing the data. And then Erin, your competitive spirit of making sure that you execute. And Megan, I'm sure you're looking at these numbers regularly. How do you get staff buy-in to sort of drive these outcomes? How do you get the staff to understand why it's important, but also to help you operationally at the point of care or in other ways to drive these screenings? I'll start with you, Mikala.
Sorry, I defied my mute. I think, buy-in is always hard with staff. We have kind of a competition with it. Everyone loves a good competition. But then I also think, we're an FQHC and we're one of the smaller FQHCs in Phoenix. And I think with that comes staff who really care about the community. And so I think with our staff, when we explain it from a human level, that this is, how we're helping these patients. And then when we show them, all of the work we're doing to find grant funding, to do colonoscopies and all of those things beyond it, I think the staff recognize the importance. So for us, it's staff education, but then also kind of making it a human level for them. They get to know those patients. So explaining from a patient perspective, this is, how this person's journey, and making it real to them. And then I think that the buy-in is easy.
Empathy-based kind of care and operations. I love that. Erin, what about you?
Oh my gosh, this is like my passion. I could talk about this all day. I spoke in a conference for an hour just how to create a culture of quality. So you have to cut me off. But yeah, we like Mikala, we love the competition. We do tons of contests all year on both process and outcome, right? Which care coordinator can do the most phone calls? I don't know, just little things. And then everyone has an incentive goal at the end of the year, and colon cancer screening rate is one of them. And that's for all staff. So many people are tied to that. Community health workers, providers, anyone who does this work has their own goal. And then I think it's just data transparency. A lot of the same things. Everyone gets our dashboards. Everyone knows their data. We bring it to many meetings. My team is great, just kind of being the cheerleaders of it. So just kind of talking to all staff about it, because everyone should really be a champion of this.
That's wonderful. I mean, Megan, you have a 75% colorectal cancer screening rate. I'm really curious about what project or intervention has helped you achieve that success.
Yeah, that was 75% last year, 77% this year.
Wow.
And I will say, this is one where we don't have to push as hard. Our staff are really on board, and so are our leadership team and so many of our patients. We have a 100% patient board, and almost every one of them have a family connection with colon cancer in their story. And so they're helping us push and support that. Each one of our communities does get dashboards and regular report cards on their colon cancer screening rates. We are sending them, their due lists, and then flagging every chart. Hey, reminder, this patient needs a C-scope. And we're getting those done. And that procedure tech that I mentioned, she is dogged. She will get all of the patients persistently reaching out and contacting them. One of the things that we do is when there is a diagnosis in our region, that is a great time with the family's permission. They help us capitalize on that. So contacting all of their extended family. And even those that aren't biologically related, that will be the trigger that gets them to come in. And we find that once patients have gotten the first one, it's really easy from there. So we work really hard on getting patients that first colonoscopy as close to 40 as possible. In Alaska Natives, we start screening at 40. And in our non-native population, we, of course, start screening at 45. So if we can get people set up as close to that 40th birthday with their first screening, then we know it's a much smaller hill to climb as they age. And staying on top of it, just with good data management, this one isn't quite as hard for us.
That's incredible. Do you all have playbooks, written playbooks to get people engaged in this program, or trainings, or do you find that it's seamless across departments to help sort of execute against your cancer screening program? And anybody who wants to unmute. Erin, I know you can talk about it all day. Megan,
I don't have any playbook. Every day I just wake up and I'm like, what should we try today, team?
I think there's honesty and authenticity in that. So it's good to
true.
For folks to hear.
I literally have a wall that's full of Post-it notes. If I get an idea, I just stick it on the wall.
So it's more about just getting people excited and knowing that we might not get it perfect each day. But we got this. What about you, Megan? I saw you on mute.
Yeah, I mean, I think we don't have something clearly that's a playbook, but we are, discussing at the medical staff, the nursing staff, the administrative level, ongoing these rates. Our CEO brings them up and is holding us accountable. And our patients are also holding us accountable. And I think that helps. I will say we struggle more on PAPs and other things, but on these, that accountability has really kept us moving forward. Of course, we struggle, bad weather week, we can lose a whole week's full of patients that we're supposed to fly in for exams. So coming up with where we create playbooks is, what do you do when that happens? When a storm happens and all these people can't fly in? Well, we have a wait list of people who are in Nome who can drive in, or we can go pick up with bus and bring in for colonoscopies. And we tell them, hey, we may call you this week, and be prepared. And our patients are generally pretty good with that.
That's really helpful. Thank you, Megan. The waitlist piece is really important. The work goes on even when we face sort of these emergencies, like weather emergencies, and certainly for other communities, immigration-related emergencies. So we've seen people develop those types of playbooks as well. So that's really helpful. So what about some advice for the people on this call? Many of the people on the call may be at community health centers themselves, free clinics, tribal health organizations, and they're trying to move the needle, often with limited resources. What would you absolutely recommend that they do, and what would you recommend that they avoid doing? We'll start with you, Mikala.
I feel like that's such a loaded question.
I don't know
what I would recommend anyone not do, because I do feel like Erin said, you just have to try things. You have to come up with ideas and try it. And sometimes you're successful and sometimes you're not successful, and that's okay too, because you tried it. For us, we're really small and we don't have a lot of staff. So we don't have people to outreach via phone and things. So we're using these digital tools with the text, the text outreach, that type of thing. We're always looking for funding. We did find some funding to assist to pay for someone, a staff member to do outreach to the positives, and we were able to pay for some colonoscopies, but that was a short amount of time, So we were able to kind of plug that hole for a year, and then we've had to get creative since then. But I think it's really just creativity, looking at the tools you have, looking for funding. Sometimes it's asking other organizations too, what are you doing? We did the mail out and that wasn't a big success. The biggest thing I think we have is our staff, and our staff, like we talked about, removing that stigma, constantly having that conversation, because it can be just a little blip, make sure. And then the front desk, when they check out, it's, hey, remember to bring that back. Do you have any questions about that? It's that constant, everyone's, Erin said that too. Everyone is talking about it. Everyone is on the same page of, this is what we're here for. And this is kind of what our patients need. And that would be my advice, which I don't think is like anything, huge and mighty, but when you're a small organization as well, you have to use the tools you have, because you don't have always the staff outreach and that type of thing.
That's super helpful. Thank you. What I heard is think about funding sources that will undergird or support your program. I heard you say, think about small micro adjustments in your operations, like destigmatizing at the front desk, reminders in different channels where you connect with the patients. I also heard you say digital tools, which makes us feel really happy, because we want to be there with you as you're trying to drive success on these programs. And part of the digital tools is it helps you scale, because you can't just jump on a call with everybody. And then I also heard you say, like, not every program works. So you sent it out and you mailed it out. That didn't work. So go ahead and ask other partners what they're doing and try things. Don't be afraid to fail. Love that. Erin, I'm going to go to you.
Sure. I was resonating so much with what Mikala said, so I'll try not to harp on it. I'll start with what not to do. So to build off of Mikala, like, when something goes wrong, let it go. I guess it is something to do. I think sometimes I beat myself up and I'm like, let me just find another way to try this. Or like, I dragged out projects for way too long. That's just like, if it doesn't work, just move on. Like, you're not a failure. Lesson learned, put it in the, like, we tried this, and write it down though, because I think if you're like us and you've been somewhere now for a few years, it might actually work later. Like, it might not have worked at the time. So like, save your ideas, and then maybe you have to wait 5 years. So move on. I hold on to things too long. And so, but something that I've loved doing, and if some of you don't know where to start, or you're feeling overwhelmed, ask the patients. And so one of my favorite things to use Care Message for has actually just been to text them, like, what's your deal? Answer A, B, C, or D. And you could parse out
You literally say, what's your deal?
Yes, that's all it says. What's
We
up?
checked. That's what you say. No, just
I checked my table space. So let's say you want to text everyone who's just due and has no order. All right, well, maybe you text them something like, did you know you're due? Write back yes or no. We love to text people with an outstanding order to be like, what are your barriers? And then with all the responses, we then divvy it out and get it to the right staff. So if they have like insurance concerns, that can go to someone. If they're like, I don't know what you're talking about, lady, that can go to a different group. So just ask them, because sometimes I was like, oh, what should our project be? And I'm like, I'm going to just stop assuming what the patients are thinking, and I'm just going to ask them. Yeah. So we do that a few times a year, and it's great. And even if 20 people reply, whatever, you get those to the staff. And I see in the chat, like, some discussion, like, it's whatever your rate is, like, just start with 5 people, 10, like, it's all you can do, chip away at it. So that's a project I've enjoyed.
Yeah. Super helpful. Just to ask the patient. It seems simple, but I don't think it happens as often as we think, right, Erin? Megan, what about you?
I will say I agree there. So for the patients who are not, responding, it's the easy ways, but we do send, and we actually just sent our reminder this week out to patients, and we use that ABCD choice. But one thing that has been really effective, whether it's the in-person or all the communications, is we go with a presumptive yes. So you approach the patient with, okay, you need your colonoscopy. Do you want it this week or do you want it next week? And with the question of, okay, so we text out, you're due for your colonoscopy. Do you want to have it this week, this month, or next month? Or do you want somebody to call you to schedule at a better date? Or do you want to know more about fit tests? We kind of offer that as like choice number 4, but all of it with the presumptive instead of with a presumptive no. we are working with all of our staff, nursing, medical, et cetera, to, with each of our focus areas and everything we want them to do, come with a presumptive yes. Presume they're going to say yes to the vaccine. Presume they're going to say yes to the colonoscopy, instead of presuming they're going to say no. And then if there are barriers, finding out what those are and working with our team to bust barriers. They certainly exist. Oftentimes for us, it's housing and transportation. Sometimes it's finances. Sometimes it's substance abuse. And we have routes to deal with all of those.
It's very helpful. And we're so grateful to hear, I sort of feel like we're sitting at the desk with you guys in these huddles where you're looking at the data, trying to decide, there's complexity here. How are we going to address it? And the humanity and empathy, but also the strategic data-driven approach that you take is resonant for all of us. So I'm going to end with this question before we go to audience questions, which is just, what are you excited about? There have been and are advancements in colorectal cancer screening. Is there anything that you're really looking forward to trying, and what really gives you optimism about the work that is ahead? I'll go back to you, Megan, before going to Mikala.
Thank you. I think we are optimistic as we've tracked and seen the data change. We've gone from screening rates in the 40%, to now over 75%, with our goal of 80%. We keep moving that goal upwards. And I think that's our optimism is that we see what we're doing, we see where it works, and then identifying, okay, who are those patients it's not working for, and what can we do to overcome those last barriers, and the hill doesn't seem quite so high to climb anymore.
That's great. And as Cecilia said in the chat, we just love the personal connection that you have with the patients that's driving your work. And so that makes us optimistic. Mikala, what about you? What advancements are you excited about, and what's making you optimistic about the work ahead?
Yeah, so we actually are looking to partner with some med students to be able to offer more colonoscopies after we have positive screenings, because that seems to be, we've done such a great job with screenings, but the barrier starts to become where we can reflex the patients to after. So I'm really excited that that's kind of our next step, is finding those diagnostic testing, options that are more in reach for our patients, because that's kind of the next hurdle we're getting to. So we are, that's what I'm excited about, is that we're continuing to grow our screening rate, but then also giving options for that diagnostic testing as well, because that's our next barrier we're kind of trying to hurdle over.
No, I appreciate you sharing that. One of the conversations we have with our strategy team, led up by Cecilia Corral, is not every patients need options as well. And I think that, especially for low-income patients, is a hurdle that needs to be overcome sooner rather than later. Erin.
Yeah, not an advancement.
What's your deal? I should say that.
What's my deal?
Yeah.
Oh my God. I shouldn't sign up for these things. I just had my first provider reach our goal of 80%. So it's fun. I feel like once one hits it, they all build that, and they look to each other. And I love the peer motivation. So that's something internal that's keeping me motivated and excited. But advancements policy, when that age dropped, it just felt so good. It's getting, more and more rare these days to have data, drive policy. So when, that was paid attention to, that, there was that 15% increase in cancer cases for people under 50. So we're going to move the age, thank you. And that insurance companies got on board, UDS, everyone got on board. And that I really hope we see a difference. I hope we're saving more lives. Maybe it'll even go down more. But I was very excited for that move. It still feels recent to me. And it's fun to get, when someone turns 45 now, we also do text to them, happy birthday. Did you know you need a cancer screening? So it's been fun to educate that group of people on their options now. So that's something I'm excited about.
Great. Thank you. So thank you very much. It's so powerful to hear from all of you about your strategy for driving these programs. And I'm just going to ask a couple of audience questions and unmute if you want to answer. I really love this one. One of our audience members asks, how do you bring sustainable change in human habits that truly empower patients to stay healthy? I understand how difficult it is, but what would be your recommendation?
So this is Megan. I will just say, I think thinking positive. Presume that it's going to happen. Presume that the patient's going to do it, and then identify the barriers that are keeping it from happening, making it not the patient's fault, not the patient's failing, but identifying the systems around them that aren't supporting them. I want to comment Erin's birthday. We send every patient a birthday text on their birthday every year. We also send them a birthday card. We use a checklist that says, happy birthday, and here's all the things you're due for. And because we put it in a birthday envelope and we put a stamp on it, don't send it through, it's not an automated letter, the patients all open it because it's a birthday card where they were not opening plain letters. So that was one of our tricks.
And that's not insignificant. You have 10,000 patients. So that's incredible.
I have some great high school interns.
Leveraging interns, leveraging staff at different levels, definitely is a signal of the maturity that you all have as well. And the optimism thing should not be dismissed, because I do think what you think about the patients you serve affects how you serve them. And we shouldn't underestimate that, like having the feelings that they will do the right things, that they want to do the right things, that they're doing their best, especially, we hear things like they're not responding, and we realize it's just time of day. They're an hourly shift worker. My mother was a caregiver, and she wasn't going to respond in the daytime. She was going to respond at night, and so just trusting the patient really makes sense. Anyone else want to answer that question from the audience?
Yeah, I would like to say for us, we also really try to focus on where the patient's at. You might, today might not be the day to bring up, for instance, we have a mobile medical team. And sometimes that patient's sleeping on the street and they have a lot of things and a lot of barriers going on in their life. They might not hear you today, but they might be coming back in 3 months, and they might be in a better headspace and have a better, their circumstances might be different. And then that's a better time to have that conversation. So I think it's also listening to the patient and understanding where they're at. While we always want to make sure all of our, UDS measures and all the screening rates are done, sometimes the patients will say, well, I know we'll tell them you're due for this today, but if you're not in a place that we can focus on this today, let's focus on this next time. And so I think really allowing them to have ownership of their care as well is important. So then you're not just speaking to them as a number, as a checkbox. We have to check all these boxes for our measures. Really, making sure that they feel some sense of control of their health as well. Creating that partnership.
Yeah, I mean, it's so powerful. And just to spell it out, it's powerful because you guys are responsible for the denominator and for these outcomes in your contracts, right? So you have this financial pressure, but you're reminding us that, like, you can have humanity in the face of the financial pressure. And I just don't want that to be lost, because I know, having talked to all of you, what you're really facing. So that's really powerful. The next question here is, you have these strong screening rates. How have you noticed improvements in overall health? So getting them in to screen, how have you seen overall health improve in terms of quality benchmarks, for example? But also, what have you done to drive that? Erin, any thoughts there?
Sure. We have analyzed this because of course I did, that you will find that people who complete your cancer screenings might also be the ones with their diabetes controlled, might also be the ones with their hypertension, or they're working toward it. Or we look at engagement a lot. I would really recommend that people run their data. Maybe if they're not happy with their rates, are patients at least engaged? Is that somewhere you can start? Do they have 3 visits a year? Whatever. So we do look at that. And I think, again, that culture of quality, like when you start with one measure, it's none of them are in a vacuum. Your teams are going to get excited. They're going to be like, well, what else? none of these measures is just one, it's the whole person. I think it's what Megan and Mikala just talked about with it ties very much to, Anu had the great questions to the first question. So yeah, I think it's just building that maybe colon cancer is where you start, but wow, like the doors that will open when you bring on more measures slowly, and you're going to talk to the patient about all of them eventually, check off one in each visit if the patient's open and how much they can handle. And I have noticed we're kind of, it rises. Like PrimeCare is doing very well in all quality measures. It's something we're very proud of. And I think that it was the team working together on all of them.
Wow, we're so blessed to have you guys as partners, as customers. Even from like a competitive standpoint, Erin, it's like, oh my God, these are our customers. That's how we feel.
Okay.
And so we're so grateful to partner with you. And as we come to a close here, I just want to say, I think what you guys have demonstrated is that success and excellence in the safety net isn't theoretical. It's easy to look at kind of a UDS number and say, this organization's doing well, this one's not. It really helps that we've been able to unpack what goes behind achieving these successes, both on colorectal cancer screening, but everything else that you all do.